Hello, my name is Kevin Hatton, and in this presentation, I'm going to discuss the basics of acid-base balance, or as I sometimes like to say, this is a way to find the true meaning of all those numbers on the ABG. This is going to be the first presentation in a three-part series. This first presentation is really just the basics of acid-base balance and an orientation to my general approach to this complicated topic. The focus will be in differentiating between the primary acid-base abnormalities. For many people, the second presentation is significantly more complicated. In it, I will describe my approach to deciding whether this is appropriate compensation for primary and secondary acid-base abnormalities. Because this second presentation can be a bit more challenging, you may need to listen to it a few more times to truly understand the topic. The third presentation is a series of practice problems. In this presentation, I will demonstrate how I utilize the standard approach from the first two presentations to evaluate acid-base balance at the bedside. Overall, I hope these presentations will help you provide better care to your patients. My contact information is at the end of each presentation. Feel free to contact me with questions or concerns about this or any of my presentations at any time. This slide is the obligatory conflict of interest disclosure. As you can read yourself, I have no conflicts to disclose related to this presentation. As you can see from this slide, the major educational objectives are to, number one, describe a standard approach for acid-base balance analysis. Number two, to differentiate between acidosis and alkalosis. Number three, to differentiate between respiratory and metabolic abnormalities. And number four, to implement simple primary compensation analysis. All right, I hope you're ready. Why don't you go ahead and buckle up because we're about to get started. Okay, let's start with a clinical case scenario that could occur in practically any hospital, ICU, or emergency department. A 62-year-old male with chronic COPD is admitted with an acute COPD exacerbation and lobar pneumonia. On his arrival, a room air ABG and a basic electrolyte panel, well, in my hospital we call this a BMP, are obtained. The results of these labs are shown on the slide. So, a couple of questions to ponder. Number one, are these results good or bad? My suspicion is that you have a gestalt feeling about whether these results are good or bad, but maybe you don't know why you feel that way. If not, then this series of presentations should, hopefully, help you understand how to interpret these results better. Number two, what do you want to do with these results? Can he be discharged home? Should he be intubated? Or should he just be monitored closely? And if monitored for what? Again, these are all questions that I hope you will be able to answer by the end of these presentations. Now that we've introduced the clinical case, I'd like to introduce the standard steps I take for acid-base analysis on the ABG. I'll admit that these are really not mine. I suspect that almost every video, paper, or textbook that attempts to cover this topic have essentially the same basic steps to analysis. I hope that what I've done, or will do over the next few presentations, is explain each step and how to work your way from the top to the bottom, and then do that over and over and over. The key to learning and interpreting this process is repetition. Therefore, I challenge you to use these steps over and over and over. Okay, on to the steps. Step 1. Determine whether the primary abnormality is fundamentally an acidosis or an alkalosis. Step 2. Determine the type of primary abnormality in the ABG. Step 3. Determine whether there is appropriate compensation and, if not, what type of abnormalities are in the ABG. Step 4. Determine whether an anion gap is present. Step 5. Determine whether you also have a tertiary abnormality. In my experience, we do a pretty good job teaching students about steps 1 and 2. We do a so-so job of teaching steps 3 and 4, and quite honestly, we barely even mention step 5. I think we're really doing a disservice to our students when we don't discuss the entire process from top to bottom, even if it's hard to do. Acidosis or alkalosis. It's probably the simplest step in ABG analysis. It's completely dependent on the pH. If greater than 7.40, then it's an alkalosis, period. If it's less than 7.40, then it's an acidosis, period. It really is that simple. It's also incredibly easy to get tripped up by this first step. Many students get so focused on steps 2 through 5 that they confuse themselves in this first step. In doing so, they completely mess up everything that comes after. You absolutely have to get this step correct. Fortunately, it's pretty easy to just do it right. Okay, now that we've completed step 1 and determined whether we are dealing with an acidosis or an alkalosis, the next step is to determine the type of primary abnormality. There are 4 options to choose. 2 options for ABGs with acidosis and 2 options for ABGs with alkalosis. In both cases, the options are either respiratory or metabolic. You can see from the table the hallmark diagnostic features in terms of the CO2 concentration and the bicarb concentration. For example, in respiratory acidosis, the hallmark feature is a CO2 concentration greater than 40. Whereas in metabolic alkalosis, the hallmark feature is a bicarb concentration greater than 24. I was recently told about the so-called Rome mnemonic. As I understand it, for respiratory problems, the R part of Rome, the pH and CO2 concentrations are opposite, hence the O part of Rome. For example, in respiratory acidosis, the pH will be less than 7.4, and the CO2 concentration should be greater than 4. In this, they do move in opposite directions. In a similar way, for metabolic problems, the M part of Rome, the pH and bicarb concentrations move in equal ways, the E part of Rome. For example, in metabolic alkalosis, the pH should be greater than 7.4 and the bicarb concentration should be greater than 24. Both the pH and the bicarb concentrations move in the same way. This mnemonic should work, but in practice, this can be confusing because both the carbon dioxide concentration and the bicarb concentration may be abnormal in the same ABG. I will say that sorting out which is causing the primary problem in these kinds of problems can be difficult, regardless of whether you use the mnemonic or not. Okay, time for a couple of very basic examples to check your understanding. Example 1. The pH is 7.28, the CO2 is 55, the PO2 is 110, and the bicarb is 24. Is this an example of an acidosis or an alkalosis? Is this primarily a respiratory or a metabolic abnormality? I'll give you a second to think about it. Okay, the first step, determine whether the primary abnormality is fundamentally acidosis or alkalosis. So which is it? Second step, determine the type of primary abnormality in this blood gas. If you said that this ABG is a respiratory acidosis, you're right. First, because the pH is less than 7.4, this is an acidosis. Using our understanding of CO2 concentration and bicarb concentration, because the CO2 is increased above 40, then this is a respiratory acidosis. Using the Rome mnemonic, the pH and CO2 changed in opposite directions, and this must therefore be a respiratory abnormality. On to example 2. In this case, the pH is 7.45, the CO2 is 40, the PO2 is 95, and the bicarb is 26. Is this an acidosis or an alkalosis? Is this primarily a respiratory or a metabolic abnormality? I'll give you a second to think about it. Okay, again, first step, determine whether the primary abnormality is fundamentally an acidosis or an alkalosis. Second step, determine the type of primary abnormality in this blood gas. If you said that this blood gas represents a metabolic alkalosis, you were right again. First, because the pH is greater than 7.4, this is an alkalosis. Using our understanding of CO2 concentration and bicarb, because the CO2 concentration is normal and the bicarb is increased above 24, then this is a metabolic alkalosis. Using the Rome mnemonic, the pH and bicarb changed in equal directions, and this must, therefore, be a metabolic abnormality. Did you get both questions correct? If so, great job. Let's move forward. If not, do you understand what mistakes you made? If not, please review the last few slides. Please don't move forward if you do not understand this yet. Everything else from here on hinges on a basic understanding of these first steps. Okay, back to our original clinical case. As you may recall, this is a 62-year-old male with chronic COPD having a COPD exacerbation and lobar pneumonia. As you can see, we have the results from the ABG and the BMP. So, how do we interpret those labs? Well, we go back to the basics we've just learned and practiced over the last few slides. So step 1, determine whether the primary abnormality is fundamentally an acidosis or an alkalosis. So, which is it? Okay, this is an acidosis because the pH is less than 7.4. Step 2, determine the type of primary abnormality in the ABG. Again, which type of abnormality does the patient have? Well, this one is a little tricky because both the CO2 and the bicarb are abnormal. The CO2 is increased about 5 points, which might suggest this is a respiratory acidosis. However, the bicarb is also decreased, which might suggest this is a metabolic acidosis. So, how do you decide which is the primary abnormality? The best way to make the decision is to determine which abnormality is most abnormal. For example, the 5-point difference in CO2 is a 12.5% increase. This is calculated as measured CO2 minus 40 divided by 40. Using a similar formula, the 9-point difference in bicarb is a 37.5 decrease. This is calculated as 24 minus measured bicarb divided by 24. The magnitude of the respiratory abnormality is only 12.5%, whereas the magnitude of the metabolic abnormality is 37.5%. Therefore, this patient's primary abnormality is a metabolic acidosis. This may not make sense yet. This is a patient with COPD and a pneumonia. He has a very significant reason to have a respiratory acidosis, yet that doesn't appear to be his biggest problem. And I'd agree. He certainly has some respiratory problems, it just doesn't appear to be responsible for the majority of his acid-base imbalance. Okay, now that we've talked about steps 1 and 2, it's time to move on to the next step. If you don't feel entirely comfortable with these steps yet, please don't move forward. Go back, listen to my previous explanations, and try to get a better understanding of these concepts before moving forward. We are now going to switch into a conversation about primary abnormality compensation. We will start with a couple of caveats and tricks to help you navigate this part of the analysis. First, patients do not overcompensate for their primary abnormalities. For example, a patient will not overcompensate for a respiratory acidosis to a degree that the pH becomes greater than 7.4. It just doesn't work that way. That being said, it is possible for healthcare workers to cause patients to overcompensate using medications or mechanical ventilation, but even then, it's not truly overcompensating. It's creating a different and now iatrogenic acid-base abnormality. Second, patients will always compensate with the opposite of their primary acid-base abnormality. So what does that mean? Well, for example, a patient with metabolic acidosis will compensate with a respiratory alkalosis. Breaking that down, I would ask, what's the opposite of a metabolic process? It's a respiratory process. And what is the opposite of an acidosis? It's an alkalosis. So the opposite of a metabolic acidosis is a respiratory alkalosis. See if you can figure out how the other three primary abnormalities are compensated. I'll wait a second to let you think through it. Okay, so a patient with metabolic alkalosis will compensate with a respiratory acidosis. A patient with a respiratory acidosis will compensate with a metabolic alkalosis. And a patient with a respiratory alkalosis will compensate with a metabolic acidosis. First, we'll talk about compensation for metabolic abnormalities. As we've just discussed, these compensation processes occur through the respiratory system. In this way, we determine whether there is appropriate compensation by evaluating the change in the CO2 concentration on the ABG. For metabolic acidosis, we use the so-called Winter's formula. Using this formula, we multiply the bicarb concentration times 1.5 and then we add 8 to it. That is what the CO2 concentration on the ABG should be. For metabolic alkalosis, we use a slightly different formula, sometimes called the Summers formula. This is a bit of a joke as these formulas aren't really named for the seasons. Winter's formula is named for Dr. Winter, but it can be an easy way to remember it. Anyway, for metabolic alkalosis, we calculate the difference between the measured bicarb concentration and a normal bicarb concentration, or 24. We then multiply that difference times 0.6 and add that result to 40. That is what the CO2 concentration on the ABG should be. Okay, on to respiratory compensation now. This is just a little bit more complicated because patients have two metabolic processes for respiratory compensation. The first acts relatively rapidly but is not very efficient. The second system starts to kick in after about 24 hours and utilizes the kidneys for pH buffering. It is significantly more efficient. Obviously, if the patient does not have kidney function though, chronic compensation cannot work, and compensation is only through the acute cellular buffering process, independent of how long the acid-base abnormality has been going on. For respiratory acidosis in the acute setting, we multiply the difference in measured CO2 concentration and normal CO2 by 0.1 and then add it to 24. In the chronic setting, since it is much more efficient, we multiply the difference in measured CO2 concentration and the normal CO2 concentration by 0.4 and add that to 24. For respiratory alkalosis in the acute setting, we multiply the difference in normal CO2 concentration and measured CO2 concentration by 0.2 and then subtract it from 24. In the chronic setting again, because of the increased efficiency, we multiply that difference in measured CO2 and normal CO2 by 0.5 and subtract it from 24. This is all pretty easy, fairly formulaic, assuming you get steps 1 and 2 correct. Let's move on to our second set of ABG examples to check your work and see if you understand these primary compensation abnormalities. Example 3. The pH is 7.28, the CO2 is 55, the PO2 is 110, and the bicarb is 24. If you're thinking these numbers look familiar, well, it's because they are from the first example. I'm going to try to continue walking you down the process to ABG analysis. Anyway, if you don't remember, then let's start at the top. Is this an acidosis or an alkalosis? Is this primarily a respiratory or a metabolic abnormality? And then third, and most importantly for this question, is this abnormality compensated? I'll wait a second. Okay, first steps. Determine whether the primary abnormality is fundamentally acidosis or alkalosis. So which is it? Second step. Determine the type of primary abnormality in the ABG. Third step. Determine whether the primary abnormality is compensated or not. In this example, the primary abnormality is a respiratory acidosis. If it is compensated by the opposite, then it is compensated by a metabolic alkalosis, and we would therefore expect the bicarb concentration to be increased from normal. How much of an increase is predicted from the formula I just discussed? Alright, if you said the ABG represents a respiratory acidosis with appropriate acute compensation, you'd be correct. Using the formula for respiratory acidosis, we would expect the bicarb to be increased to 26 in the acute setting and to 32 in the chronic setting. Remember, compensation is significantly more robust and effective in the chronic setting. I should also say the only way to tell whether to use the acute or chronic setting formulas is from the patient's medical history. Let's try example 4. pH is 7.50, the CO2 is 35, the PO2 is 95, and the bicarb is 30. Again, if you don't remember, then is this an acidosis or an alkalosis? Is this primarily a respiratory or a metabolic abnormality? And then third, and most importantly again, is this abnormality compensated? I'll give you a second. Okay, in this example, the primary abnormality is a metabolic alkalosis. If it is compensated by the opposite, then it is compensated by a respiratory acidosis, and we would therefore expect the CO2 concentration to be increased from normal. How much of an increase is predicted from the formula I somewhat jokingly referred to as Summers' formula. Okay, if you said that ABG represents a metabolic alkalosis with incomplete compensation, you'd be correct. Using Summers' formula, we would expect the CO2 to be increased to 44. In the example, however, the CO2 is actually decreased down to 35. This patient is not compensated for their primary abnormality. Now, let's go back to our original clinical case. As you may recall, this is a 62-year-old male with chronic COPD having an acute COPD exacerbation and lobar pneumonia with a primary metabolic acidosis from his complicated ABG and BMP results. So we'll cut right to the chase. Does he have an appropriate compensation of his primary metabolic acidosis? I'll wait a second. If you said no, there is not an appropriate compensation, well, you'd be correct. Using Winter's formula, the CO2 concentration should be approximately 30, whereas on the ABG, the CO2 concentration is 45, so it's not compensated. Whew, you've made it. We've completed the first presentation. You can now take a deep breath again. In the next presentation, we will cover even more difficult topics such as how to interpret incomplete compensation, how to differentiate between anion gap acidosis and non-anion gap acidosis, albumin correction for anion gap acidosis, and finally, how to evaluate complex problems, including the triple blood gas abnormalities. Thank you for watching this presentation. I hope you've been able to learn something useful that you can apply to your patients today, tomorrow, and for a long time in the future. If you have any thoughts or comments, I can be reached at the email address on this slide. Thank you very much, and have a great day.